So we're often taught with a lot of the deformities that we see that the lateral femoral condyle can be hypoplastic. And what we're basically doing is we're referring to the presence of valgus deformity at the level of the knee. And hopefully you're seeing a recurring theme here is that a lot of deformities that we see and assess are multifactorial, multiplanar. And understanding that sometimes can be difficult. Until you get that understanding, managing them is difficult. Now, you've self-selected by coming to this course in terms of being able to identify that understanding and treating deformity is critical to all aspects of orthopedics. So in other words, I'm saying you're a good audience. But we need to be able to recognize the elements that make these up in order to treat them. And for that purpose, we need to cross almost two worlds. So you have your pediatric limb reconstruction surgeon, tends to be very clever, can do more than 3 operations and understands deformity and can change ligaments, but will tend to change the alignment of the bone to help where there is underlying ligament deficiency. On the other flip side of the coin, you've got me, and I can say this because I think I'm the only kids knee surgeon here unless everyone puts their hands up. We think we're smart, but we're not. We can do 3 operations, basically. And we draw a line from the center of the hip to the center of the ankle, and then we look roughly where it is in the knee and work out whether they're varus or valgus. But we will reconstruct ligaments to compensate for bony deformity. And you need to have some degree of compromise with these 2 schools of thought, because often what you're trying to do is balance a rugby ball on top of a football, and that's not something that's easy. So true lateral condyle dysplasia meaning something has failed to form properly, we'll see that in discoid meniscus, which is what this video is showing you here. But invariably, it's not something that directly affects outcomes of treatment of discoid menisci, or it might do, we just don't know about it because of the follow-up. But where we see it in its bad tends to be 2 main groups: skeletal dysplasias, things like pseudoachondroplasia, and congenital limb deficiencies, particularly congenital femoral deficiency. But you can see it in other pathologies, like in long-standing inflammatory arthropathies. When you're assessing for valgus of the knee, a bit like Gamal divided it up earlier, you can have extra-articular deformity, so diaphyseal, metaphyseal problems, both of the femur and the tibia. Or you can have intra-articular pathology, which is where hypoplasia of the femoral condyle or the tibial condylar surface comes into play. But also ligamentous laxity, both at the knee but also at the foot and ankle, can affect the alignment of the limb. But all 3 can coexist. And the ones that are hardest to treat is where you have incongruency of the joints. So why is the condyle small in these sorts of patients? Is there a defect in the physis? Or are we seeing the mechanical effects on the physis causing the condyle to appear smaller? So is it a bit chicken and egg? Is it the malalignment and compression that causes the condyle to develop less commonly because of the way the forces pass through the knee? But remember, a lot of the cases where we think they have hypoplasia of the lateral femoral condyle, it's actually apparent. And this is a nice study from France where they took 200 patients who had valgus alignment and were going to have a knee replacement for arthritic change. Basically, they did CTs and mechanical axis views. And what they found when they looked at them, don't worry too much about the graph, this is looking at the volume of the condyle depending on how much valgus you have. And you can see we go from the left of the graph to the right of the graph, the valgus increases, but actually the volume of the lateral femoral condyle relative to the medial, it goes the opposite way to what you would expect. But it also shows that true valgus, most of the time in this cohort of patients, it's coming from deviation of the anatomical lateral distal femoral angle. But more interestingly is that there is a torsional problem in the distal femur. And that correlates quite closely with valgus alignment in this cohort. Bearing in mind, these are not elderly, they're elderly for me, but they're an older cohort of patients who have arthritis there. We're not looking at congenital pathology here. Now, one thing that's very useful in managing these is the use of guided growth. Now, we must be aware that we do a lot of these procedures. There is now starting to be a little bit of evidence that treating coronal malalignment with guided growth can affect the parameters of the other structures in the knee, because the distal femoral physis is quite complicated in structure. And we're only now starting to get better understanding of how the trochlea and how the femur develops as a result. But these cases where you see a congruency of the joints with a hypoplastic lateral femoral condyle that's associated with the valgus are good cases to treat with guided growth. An example here, someone with absent ACL with congenital femoral deficiency, albeit mild, managed with ACL reconstruction and concurrent guided growth. And another case where we've done ACL and PCL, and as you can see, James has subsequently gone on to lengthen the patient. Remember, we talked about deformity recurring, and you can see here, he's coming towards skeletal maturity, but we're in a better place than when we started, and we're not struggling with instability and functionally doing quite well. Now, the other thing is that we know that the morphology of the knee will change according to the forces that are across it. I've told you that. This paper gives you a little bit of evidence of that. It's a small study, 20 skeletally immature patients with patellofemoral instability who had surgery to realign the patella. And they use CT for their follow-up. And when they looked at these patients after patella relocation in comparison to the other knee, okay, it's not a great way to get high quality evidence, but what they found was the posterior aspect of the lateral for the left femoral condyle grew more than it did on the opposite side. So in some ways, the forces across the knee, be it patellofemoral joint, be it tibiofemoral rotation, affects the way your condyles develop, but we don't fully understand the whole process. But one thing perhaps for you all to take away today from these patients is ligamentous rotatory instability. Gamal talked about this earlier. And we're finding that we're learning a little bit more from the adult literature where there's been an increase in research and publications on rotatory knee instability, particularly anterior medial rotatory instability. This picture is from an article by Slocum. So someone's always thought of something before you think you've thought of it. So I didn't know about this. I had to speak to my colleague over there in the corner who told me about this procedure, pes anserinus transfer, which was being done for rotatory instability of the knee. And this has probably worked in a different way to what we expect, because what Slocum thought was by bringing the pes forwards, you convert a flexor to an extensor and it controls rotatory instability. But what we know now from the work being done in the adult patients is that the deep MCL is a strong resistor to anterior medial rotatory instability of the knee. And our focus has gone in ACL reconstruction to lateral instability, which is where the role of lateral tenodesis has come in. And maybe we've missed this. So these are major things that prevent deformity and are probably going to be weak as a result of underlying deformity, abnormal gait mechanics, and need to be considered. So case example where the lateral condyle looks hypoplastic. So this kid has had 2 failed MPFL reconstructions. First time as soon as he came out of the brace, second time in recovery after his surgery. So if you look at this leg, it looks complicated. You might say the condyle is hypoplastic, but actually it's not. What he's got is anterior medial rotatory instability and tibiofemoral rotation because he's got long-standing rotation laterally of his quads, and the tibia will rotate to compensate for that. So there is underlying deformity here. Don't get me wrong, that's not been addressed by this surgery, but the kneecap is back in and he can now function. So also, we've talked a little bit about congruency, but to pick up incongruency, you need to be a bit careful. You have your deformity parameters, which you've learnt about this week, but sometimes stress radiographs are useful. This case here is, again, a congenital ACL deficiency, but they also have tibial deformity. But here we can see the position of the leg with the tibia reduced, okay? And as you can see, there is maybe a little bit of hypoplasia of the lateral femoral condyle, but nothing dramatic. The actual treatment for this is ACL reconstruction and correction of the tibial deformity. So arthrograms can also be helpful. And this is something that you will do in terms of planning in theatre sterile environment, and you can do a formal EUA. If you don't understand if congruence is there or if congruence is not, this is something that can help you make your decision making. But nothing substitutes for good clinical examination. This is a boy who's had a previous SIMS, proximal tibial guided growth, for quite significant fibular hemimelia. And this is the issue that we talk about, long-term follow-up. If you look at these patients, how many problems they have. So he can't walk because as soon as he puts his prosthesis on, he's in pain. Now, where is that coming from? You can see there his x-ray, but the knee is subluxed. So that's what he looks like in the lateral view, and that's his picture from theatre in terms of how it's reconstructed, where he's had an ACL anterior medial reconstruction with allografts. And that does help, but obviously is not the whole solution to the problem. You look at the post-op x-rays, which are at 3 months, and that's a clinical photo of him moving. He's now wearing his prosthesis and he can walk without pain. But long term, what's going to happen? Because have I addressed all the elements of that? Now, where the joint is incongruent is where my knowledge stops, and hopefully some of the faculty start, because I can't find much in terms of evidence on how you deal with this. There are people who will do advancement of the lateral femoral condyle to compensate, and we know that it works for Blount's disease. Blount's disease, we do hemiplateau elevation. Obviously, a little bit more complicated than just lifting up the tibial surface on the medial aspect. But this tends to be something reserved for cases where there are skeletal dysplasias, simply because in those patients, when they're skeletally mature, you have incongruency of the joint. But remember, if you're going to do an osteotomy of the lateral femoral condyle to advance it and restore that congruity of the joint surface, you're probably going to do it in a way that's going to affect other aspects of the deformity, so it's not without risk. And in essence, unless you're doing like a wedge to reconstruct, you're taking the whole lateral condyle off as an osteochondral graft. So that can be quite risky. So maybe there is a role, certainly not in my practice. So to summarize, lateral femoral condyle hypoplasia is multifactorial, and the true cases we see are those that have congenital limb deformities or skeletal dysplasias. It's in the general population, it's probably more chicken than egg, but then it's difficult to know. But older patients, it's less of a problem, and it's probably more related to the underlying alignment. Guided growth is a good option for those who are skeletally mature because it gives them time for the contralateral side of the joint to compensate, and you can also treat that side. But always assess carefully for associated limb ligamentous instability. Make sure you've corrected the extra-articular deformity, and true incongruity is quite complex and actually very difficult to treat. Thank you.